Hello and welcome to this Pediatric webinar, OX40, Innovative Insights and Therapeutic Potential in Pediatric Dermatology. I'm Jen Dawson, Pediatrics Director of Educational Programs. Before we begin, I would like to thank our program supporters, Amgen, Sanofi, and Astria Therapeutics. Thank you for supporting this independent medical education program. Pedra is solely responsible for all program content and the selection of all presenters, authors, moderators, and faculty. Now, I would like to introduce our program moderator, Dr. Joy Wan. Dr. Wan is an assistant professor of dermatology at the Johns Hopkins University School of Medicine. Her areas of clinical expertise include pediatric dermatology and atopic dermatitis. In addition to her clinical practice, Dr. Wan leads an active research program focused on epidemiologic and patient-oriented investigations of pediatric skin diseases, including eczema. Dr. Wan has been a very active member in Pedra for many years, serving on several committees, giving many talks, and mentoring many trainees throughout her early career. Thank you so much for moderating for us, Dr. Wan. I will turn it over to you.
Thank you, Jen. I'm excited to moderate our OX40 webinar today, and we're really delighted to have Drs. Larry Eichenfield and Eric Simpson with us here today. Neither of them really needs an introduction to this audience, I think, but for those of you who don't already know them, just bear with me as I provide a brief introduction, okay? Dr. Eichenfield is Chief of Pediatric and Adolescent Dermatology at Rady Children's Hospital in San Diego, and Professor of Dermatology and Pediatrics, and also Vice Chair of the Department of Dermatology at UC San Diego School of Medicine. He's triple board certified in dermatology, pediatric dermatology, and pediatrics, and he's had longstanding expertise in atopic dermatitis, which we'll discuss today, but as well as acne, psoriasis, basically all the pediatric dermatology conditions that we care for, having authored numerous papers and some of the seminal textbooks in our field. Dr. Eichenfield has held multiple leadership positions, including being the co-founder and co-chair of the PDRA and co-chair of the AAD's guidelines for atopic dermatitis. Dr. Simpson is the Francis J. Storrs Medical Dermatology Professor of Dermatology at Oregon Health and Science University School of Medicine. He practices medical dermatology with a special interest in chronic inflammatory skin diseases, including atopic dermatitis. And skin cancer as well. And he's actively involved in a lot of clinical research focused on atopic dermatitis that's been funded by the National Institutes of Health as well as industry partners. He directs the Francis J. Storrs and John M. Hanifin Clear Eczema Center at OHSU and holds multiple leadership roles in organizations such as the National Eczema Association and the Harmonizing Outcome Measures and Eczema Home Initiative. So I think for a webinar on atopic dermatitis and OX40 and pediatric dermatology, I really can't think of two better suited speakers than Dr. Eichenfield and Dr. Simpson. They're both internationally recognized for their expertise in AD, and it's really a privilege to learn directly from them as part of our programming today. So with that, I'm going to hand over the Zoom floor to you, Drs. Eichenfield and Simpson.
Eric and I have sort of titled it Preparing the Dermatologist for the OX40 Revolution, and I'll start off by saying that what's OX40 and putting it in perspective. A few years ago, most dermatologists weren't familiar with IL-4 and IL-13 or IL-31, and yet now we sort of pretty much are comfortable understanding to some degree how they mediate inflammation. And OX40 is a different pathway that is being targeted as anti-inflammatories for atopic dermatitis. So we're going to go, so I'll start off, discuss a little bit what's OX40, then what's the biology behind it with not a lot of detail, but enough to understand how the OX40 ligand may mediate some of the inflammation, particularly tied to atopic dermatitis. Then Eric will discuss a little bit of concept about disease, changes in disease, either remission or modification of disease, as a setup as we move into the clinical data on some of the drugs that are being developed targeting OX40 and OX40 ligand. So which of the below is correct about the immune checkpoint molecules OX40 and OX40 ligand? OX40 is expressed on activated antigen-presenting cells. OX40 ligand is expressed predominantly on antigen-presenting cells. OX40 ligand is an inhibitor of keratinocyte proliferation. OX40 blockade cannot deplete activated T cells, or OX40 is named in relation to castrated cows. So remember, an ox is a castrated cow. That's where that came from. So this may not be walking knowledge, or it could be, but in fact, there is a difference in terms of where OX40 is expressed and OX40 ligand is expressed. The correct answer to this answer happens to be that OX40 ligand is expressed on antigen-presenting cells, and OX40 is expressed on activated T cells that aren't antigen-presenting cells. So let's take a look at some of the information behind how OX40 and OX40 ligand mediate inflammation. OX40 ligand and OX40 are co-stimulatory immune checkpoint molecules, and they're important in regulating or impacting on effector cells and memory T cells. So T cell activity, both T memory T effector cells, are affected by OX40 and OX40 ligand, and they promote sustained immune responses in multiple pathways, including in general Th2 helper cells, as well as Th1, Th17, and Th22. Thus, they have become targets for blockade, seeing if blocking their immune responses might impact on decrease inflammatory activity. Here we're looking at what's listed on the left: T cell activation, OX40 ligand signaling. So we'll stay to the left. So OX40 is expressed or induced on activated T cells. So, and OX40 ligand expression is induced on antigen-presenting cells. So they work at different parts in the pathway. So let's start in the middle. I have an antigen-presenting cell there. OX40 ligand is sitting on the surface membrane, but you should know that naive antigen-presenting cells don't have OX40 ligand on them. But as they get dedicated to antigen response, OX40 ligand makes it to the surface, and it impacts on antigen presentation, and therefore can impact on activating T cells. And by activating T cells, so the stimulation of OX40 ligand with OX40 in activated T cells can impact on the expansion of T cells. It can inhibit apoptosis and increase T cell survival, and it can sustain OX40 expression. So therefore, you can have sort of an upregulation in number and activity of T cells. If you go to the left of that, these activated T cells can have OX40 on them, and there's these set of activated T cells that can go on and do their damage. And you'll see as we start to talk about the difference in two of the major drugs that are being developed, one of them targets OX40, so it targets sort of the already activated T cells, and OX40 ligand is impacting on the antigen presentation and potentially proliferation of cells. So I was trying to come up with some analogy. It's probably a bad one, but let's say some kids become bullies at some point in their lives. So they start off as naive kids, not necessarily pre-targeted to be bullies, and there are some factors that may stimulate them to become bad actors over time. So OX40 ligand targeting that is targeting some of those factors that may cause a proliferation of these bad effector cells. And blocking them is different than depleting a bunch of bad effector cells, which may be more of the target for OX40 expression. The impact of this is that OX40 and OX40 ligand is going to impact on the expansion of the effector CD4 and CD8 T cell populations, and would upregulate cytokines and promote the survival of T cells, and blockade of either of those may impact on those cell populations. The OX40 and OX40 ligand is activated through a variety of pathways. And I think this is the point at which I can't tell you differential effects on these different pathways. We know it affects the PI3K, PKB, AKT, NF-kappa beta 1, and NF-AT pathways as the way that they mediate cell growth, survival, and inflammation. I don't know if there's any insights that we get beyond knowing that in terms of the details of its effects. Now let's try to talk about specifically how OX40 and OX40 ligand stimulation can impact inflammation, and then move over to discussing it in atopic dermatitis. So here we're seeing OX40 and OX40 ligand with an antigen-preventing cell and an activated T cell. And in the face of an inflammatory milieu, you can have clonal expansion of the cells with suppression of FOXP3 that decreases Tregs. And then you get this preferential action on antigen-specific T cells, which will give you clonal expansion of T cells. Now, OX40 and OX40 ligand has some impact on a variety of immune diseases, including some autoimmune diseases. Atopic dermatitis we'll be discussing today, as well as psoriasis and SLE. And OX40 agonists can actually activate tumor infiltrating cells. So in that case, an upregulation of these inflammatory cells can be utilized as an anti-cancer or potentially as an adjuvant for vaccination. And if we look sort of at OX40 and OX40 ligand signaling for atopic dermatitis. So first of all, there's a variety of antigen-presenting cells in atopic dermatitis. You can see on the right. But then if you move to the left, this is sort of a summary of how our stimulants, which may be barriers, disruptions, allergens, bacteria, that present antigen, can then stimulate antigen-preventing cells and convert naive T cells to activated T cells. And that can be influenced by the OX40 ligand impact on antigen presentation. And then potentially mediating OX40 can impact on getting rid of activated T cells. And actually some of the blockers will deplete activated T cells, having an impact on inflammation in atopic dermatitis. And so we're going to, as I shifted over to Eric, I just wanted to sort of translate this to particular drugs in development, because the OX40 blockade, we have two different drugs that will block OX40 and impact on activated T cells. And then we have another drug, that's Rocatinlimab and Telazumab. And then Amlitelimab is targeting the OX40 ligand and the antigen presentation. Hopefully not as confusing as it might have been before if you haven't spent time looking at OX40 and OX40 ligand. But you can see sort of the background to set us up to how blockade may influence inflammation in atopic derm. And we can maybe turn it over to Eric for the next one.
Awesome. Thanks so much, Larry. I'll just give one trick of how. So I'm learning this too. So thank you, Larry, for walking through that. I remember Amlitelimab, which is not. There's no reason why I would pick that drug, but it does. If you remember that, then I remember Amlitelimab APC. So you know Amlitelimab blocks APC, and L is early more than Roca. So then it's OX40 ligand. So it blocks the ligand on the APC. So remember Amlitelimab, if you ever want to know, is it ligand or is it receptor? And is it on APC or is it T cell? Okay. We'll see. We'll see if that sticks. And what's annoying is that it's called OX40 when it should be called OX40 receptor. And I think it's perfectly fine for you to say OX40 receptor. There'll be sophisticates who say that's incorrect. It's OX40, but it really is OX40 receptor. And it's okay for me to say that. And it's okay for you to say that. So Larry said there's a lot of biology. And I think about it as, and there's a cool mouse model. Like if you knock out OX40, you can initiate the immune response. Like an APC can activate a T cell with the TCR receptor and the co-stimulatory. But what happens after that is like it doesn't perpetuate the inflammation, and like Larry said. So that's how I think about it. It's like the second half of the inflammatory cascade where you're getting perpetuation of the inflammation, and so that seems to block it. So we don't know, like, does blocking that going to help, or do we need to block it at the very beginning? So there's a lot of unknowns. But one of the effects of blocking this OX40 pathway is T regulatory cells may be awakened, okay, by blocking this pathway. And so you're going to be seeing a lot. It's good to prepare yourself for how companies, how science is going to start talking about disease modification. And it's got many, many different definitions in the literature. But this is one that's starting to stick in atopic dermatitis. And what we're talking about is like basically prolonged effects of a drug. And Thomas Bieber has this definition that I think is actually really good. It's one of two things for disease modification. And we'll get more into this in the podcast possibly. But you can either change the natural course of the disease, and you as pediatric dermatologists know that, probably a proportion of patients grow out of this, right? And so that if you could cause that to happen, change the natural course off drug, like when you stop the drug, you stay in that type of state. That's one definition. Or you change the risk of developing a comorbidity or the severity of it so that you can prevent asthma, for example, on drugs. So that's allowed to be on drugs. So these are kind of two definitions that are starting to rise to the top of disease modification. It means something in every single different disease. So, but I just kind of want you to be aware of this idea. So as pediatric dermatologists, you know that there's these, trajectories of AD, and you have this early transient, and that's where, boy, I wish we could cause that to happen. We really want to change the curve of early persistent. That's the blue line. And so, we'd prefer to like kind of bend the curve down to the orange, so that's change, and that's off drug. Can we do something as pediatric dermatologists, treat the disease at this point and change the natural course and stop the drug? And that's what these companies, I think, are hoping that this pathway may do. That's the course. But remember, there's two different definitions. Or change the comorbidities, right? So we treat eczema here, we prevent this coming through. So there's some off-drug considerations. So, what are the, are we doing this with Dupy? Are we doing this with Lebrine? Are we doing this with Nemo? You have to think about these like, then this is for a different discussion, but I just thought to kind of throw this your way. Half-life of the drug. When people say, oh, we remit the disease or we change the natural course, just be critical. What's the half-life of the drug? What's the baseline severity? How long they had the disease of atopic dermatitis? That probably matters. There's some adult data in psoriasis that matters. Or, early intervention can help. Concomitant therapy, topical steroids can make anything look remittive. Like when you stop the drug, it could keep people clear for a long time. Depth of response is probably important. Time multiplied by depth of response is probably the most important consideration for a long-term remission. And then mechanism of action. So is OX40 going to be the mechanism of action that will give us this, holy grail? This is not about OX40, but it does show, I think OX40 partially targets T regulatory cells. And this is just to show you proof of concept that you can give low-dose IL-2. This is a Nature Communications paper. This is Silverberg's. And this is a human study looking at EZ75. Low-dose interleukin-2 stimulates Tregs. It doesn't do much else other than like high-dose IL-2 is toxic. And so, but this was nice proof of concept that you can take a Treg approach to this disease with a prolonged remission after you stop at that line at week 12. So it's kind of exciting early data to show that maybe we can fool around with this part of immunity and like get some positive results. Okay, just a reminder, Amlitelimab, APC, there's an L at the beginning, ligand, blocks OX40 ligand on the APC. Amlitelimab blocks that. Rocatinlimab is the OX40 receptor on T cells. And the cool thing about Roca, or at least I don't know if it's cool or not, the different thing about it is, like as Larry mentioned briefly, it kills the cell. It's non-fucosylated. So for some reason, when you take off these sugars, it like impacts your antigen-dependent cytotoxicity. And I guess that's complement, I think, mediate boom, and you just kill the T cell. So it can actually remove T cells. So you'll see, like in marketing, Amlitelimab will say non-T cell depleting. And then in Roca, it'll say, we get rid of the bad cells. Who knows which one is better? That's what's so exciting about this. I mean, it seems like, wow, if you could permanently get rid of all the like T cells that are causing the disease, that would be amazing, right? That seems like that would be remittive. But also, I'm getting rid of my immune system in a permanent way. So it'll be interesting when we look at AE profiles, we'll start seeing differences. Okay, so now we'll start with Amlitelimab, and we only have phase 2 data. This is just to show you like the hundreds of millions of dollars when you do a phase 3 program. You have to repeat it. You have 2 exactly the same with monotherapy, no topical steroids, and you have 1 with topical steroids, and you have 1, long-term extension, blah, blah, blah. So you're always waiting for those key 2 phase 3 studies is the most important, like the monotherapy, Coast 1 and Coast 2. They're not ready yet. I have no data, no top line. So we'll look at Stream 80 is a phase 2B, which is always going to be a dose finding. So let's look at those to kind of get you excited about the concept. Okay, it's PUPS and JCI next. So it's always, lots of doses. And placebo, this is adult patients, moderate to severe AD. On the left, you can see the inclusion criteria. Usually these early 2B studies is % change in EASI score as primary endpoint with lots of secondary endpoints. Primary endpoint was at 16 weeks, but there's also 24 weeks because they didn't know, is this slow acting, short acting? How long do we make this study go? So let's look at % reduction in EASI. So baseline, greater than 21 EASI score, 70% have that across the board. That's a severe population, but it's weird because the IGA does not confirm that. So when you look at the IGA 4, if you go down 2 rows, 20 to 30% were IGA severe. So there's a little discrepancy there that I can't explain. And Larry, if you can explain me, okay. But I would say in general, this is and I'll reference everything to Dupy. That's like kind of our most well-known reference. It's a little less severe than Dupy's, which is very common for trials now. Okay, but still a moderate to severe population in adults. Next.
Yeah, and you see, a decent body surface area, 43, 48%. It's very typical of all the trials after Dupy, which is a little bit more moderate. But still significantly, moderate to severe disease.
This is % reduction in EASI at week 16. And you can see on your far right placebo, and then as you move to your left, it gets higher doses. You can see, interestingly, just first glance, not much dose response, which I have no idea why. It usually makes me worried that the thing doesn't work. But they're different than placebo. And the highest dose, the LD means loading dose. I usually just try to get you up to serum concentration faster. So those numbers they're not Dupy numbers, which are like, 65 to 75% reduction easy. So it also gives you an idea. And again, that's indirect comparisons that are just off the cuff. So take it for what it's worth. But just to kind of level set. But it works. So it's, it's statistically significant. It looks different than placebo. So that's exciting. That's like huge news that we have a new MOA that actually can reduce eczema. And then these are looking at other outcomes. So at week 16, week 24, these are dichotomous outcomes. I know this is a busy slide, but I've just take it from like a 30,000 foot view that look at your IGA scores, 5 is placebo. So that's good, low placebo. But between 15 and 20 at week 16 and 30 to 40s at week 24, that's those first columns. So,
This is 16 weeks of treatment, right?
16 weeks of treatment.
So very importantly, you're seeing numbers that are going up, especially that IGA 0/1 seems to be climbing with extended observation, even without extended drug.
Excellent observation. And if you were going to design a study on your phase 3, what time point would you pick, Larry?
Oh, well, it probably depends on half-life also, because when I say without drug, it's without continued dosing of drug.
Well, 24, they did continuously dose to 24.
Yeah. Okay.
Yeah. So I'll answer for him. I would pick 24. So because it's looking better. So it's it's going to be it's not going to be a rapid JAK type improvement, but exciting. It's statistically significant. Now let's talk about, can you modify the disease? Now we re-randomize people who responded, and response means EZ75 or IJ01, either one, at week 24. Re-randomize those to, I'm going to take you off drug, or I'm just going to continue drug all the way out to 52 weeks. And let's see what happens to your responses. So clear, the clear bars are, I withdrew your drug at week 24. Solid bars is I continued on the same dose. So again, like no dose response necessarily, but the striking thing is that the clear bars are pretty high, like they're close to the solid bars, meaning the withdrawn patients are still responding kind of 36 weeks later when they've stopped drug. And so maybe that means disease modification. They could not use topical steroids, at least in this analysis. So those are not confounding the results. And on the very far right is just kind of pooling all the doses just to make it easier to read. But there may be something to it. And so maybe we are getting a sign of disease modification.
So a few things to comment that normally when we're in this sort of design, you want to see a few things. One thing you want to see is those patients with more extended drug. Are you going to have more and more patients sort of captured in your outcome measures? And you're getting a little bit more depending on the dose, and in others, not much more. So that's one thing. And when you see that, to me, it raises the question of, are you having some patients who really respond and they stay responded? And it's not necessarily everyone who will respond, even with more extended doses. And that's just one of the things that gets tricky to figure out when you're just looking at all of this is pooled data by dose.
Okay, excellent. Now we're trying to figure out why do you have these, like, is it because do you still have drug in your system? Is that why? Or, like what's going on? Why are you retaining your responses? So on your left, if you keep treating, these are serum levels of drug depending on dose. And yes, the highest doses have the same high serum level. And if you keep treating with drug, you still have high serum level. So there's no accumulation, I guess would be one thing, but that's kind of on the left. On the middle, that withdrawal arm in the gray, you can see everything going down. So those are the people you've stopped drug. So you don't retain drug. Drug does get out of your system. And you can see, like, from week 36 to 52, it really implies that you don't have drug that's active. That's not going to have a biological effect at that 4 microgram per mil level. And so there's probably this prolonged pharmacodynamic effect, not a pharmacokinetic, you don't have any drug left. So maybe it's a real biological effect. And then on your right is just kind of the similar what we just saw last one. You just retain your responders at week 52. And remember, these are in responders. So it's a subset of your starting population. The people who respond, these are the ones that you can then withdraw drug. There's this is kind of unpublished, but it's public information that Amlitelimab said. This implies, like on our poster at the EADV, Larry, I think it was EADV, this implies we could do Q12 dosing. And so I don't know if that's public information, like they've said, oh, we're definitely going to Q12 for responders, but it was interesting that they said that. So I think that's going to be an advantage of these going to prolonged dosing for your kiddos, especially. And then this is just showing the biomarkers that are you've withdrawn drug at week 24, but your biomarkers of response, like your TARC, which is CCL17, it's a type 2, generally agreed upon, nice type 2 biomarker. EOs, more general, but all those stay reduced from week 24 on, as well as interleukin 22, the kind of border patrol cytokine.
There's a persistence of clinical response and a persistence of biomarker response.
Thank you. Let's look at adverse events from this. So Amlitelimab, remember, ligand, APC. So you're not removing the cells. You're blocking the antigen-presenting cell. And basically, it looks really good. I mean, like, I'd be worried about infection, right? We're, like, kind of generally reducing, like Larry said, multiple cell types, not just type 2. type 1, type 17. You can have impacts on mast cells. You can have impacts on fibroblasts, endothelium, like multiple different cell types potentially. So, but serious AEs, low, 2.6% SAEs. AESIs, which are going to include, those are adverse events of special interest. They will include infection, very low, 1.9%. And conjunctivitis, no signal, another benefit over current therapies. Herpes infection, another no signal, another benefit of current treatments. Worsening of AD, high in placebo as we expected. And then it's up to you whether you think 17% is kind of high in the treatment arm.
So it's a little high, but we've seen that in some other drugs as well. It really depends on what's that really like. Yeah. It makes it to a label that someone recorded it as worsening AD. Yeah.
Right. And then headache is it looks higher than. So I don't think anyone stopped the drug for headache. Okay, so that's Amlitelimab, ligand, APC, not solid. No phase 3 data yet. I cannot wait. Okay, moving to the second one is the only other one that we're going to talk about because Tela has not moved to phase 3. So we don't know if that's going to move forward or not. So you've got, Amgen and Sanofi, two amazing companies. So thank God for atopic dermatitis, that their interest in atopic dermatitis and HS and all that. So, okay, so their program, this is their phase 3 program. So huge, just like everybody else's. And then they don't have any published phase 3 data. So we'll talk about the phase 2, but then I'll show you the press releases for phase 3. So we do have a little bit of data on them.
And it's Rocatinlimab, so they're all rocket studies, as we saw.
Yes. So the first one has the water theme. This one has the space theme.
Yep.
And this is a Lancet paper. And this is phase 2B. And in moderate to severe AD, just like the last one, no topical steroids allowed at the first 36 weeks. And again, like not much dose response. The orange line that reduces the most of your y-axis is easy % reduction is not the highest dose. So again, that always makes me worried, but they're all improving, and it may be just the biology that, you don't need much drug. And I think it's when you hit some harder endpoints, I think the higher dose arms starts to matter. But I just do think it's curious. They're statistically significant better than placebo. And then when you stop treatment at week, and you get, as Larry noted with the last one, you do get continuous improvement over time, which is good. And then when you stop treatment, you can maintain your treatments from 36 to 56. This isn't quite as rigorous in terms of analysis. I was reading it really closely, the fine print. They said if someone rescues with topical steroids in that 36 to 56, that they just didn't collect data anymore. And so it's almost like a last observation carried forward almost. So I think it's really hard to always interpret when you're off drug, especially if topical steroids are used. And so I think it's still unknown at this point how Roca is going to do, which is the one that depletes T cells, how that's going to do. I really hope it's remittive, but we just don't have the data yet.
And I think just reading the curves, you saw that there is a placebo response in that first period, and then they roll over and they catch up very quickly, and then have that same, even with less total duration of medicine, they seem to maintain their clinical response over time, at least at that dosing.
And then these are just more of the dichotomy, like proportion achieving a 75% reduction from baseline, and these numbers are quite nice. So for level setting, Dupy was about 45 to 50% at week 16. These are close, maybe not quite, but then continue to improve over time. So I don't think we're going to get in this disease class head-to-head higher efficacy, at least so far, than maybe what we've got currently. But there'll be potentially these other advantages. And so you can see here, then you do lose a little bit over time once you stop treatment. But We'll have to see from the phase 3. And then just looking for completion, serious adverse events, that second row, so that's the first thing I usually look at. And that's reassuring, everything less than 6%, with the higher doses having actually lower SAEs. And then AEs leading to discontinuation, I think they're a little bit higher than the last study, where you're getting up to 21% in the placebo did discontinue, but 13% in one of the groups, no deaths. And so some unique side effects from this one is pyrexia. So that's probably from removing T cells. And you don't see this with the other drug. So that might be a difference, is pyrexia and an apathy. And these were not like severe, and I don't think many people discontinued for them. But this is a difference in AE profile, I think, because of the MOA, the mechanism of action. And then phase 3 results. So this is like, drum roll. These are just top line, not peer reviewed. And on the left is EZ75 for 3 of the phase 3 studies for Roca. Is EZ75. So from a company standpoint, all of these are statistically significant. They've all met their endpoints. EZ75, 32.8% at week 24 versus placebo, 13.7. And so, you look at this and you say, okay, Dupy was around 38 or so. You can get the JAKs up to 45, 63, or higher. Actually, those are IGAs I was quoting. So Dupy was at 50, for EZ75. So again, it looks like from the phase 3, maybe not quite as potent, but with potential added value. And it does work. And kind of similar results. So Rocket Ignite, Rocket Shuttle with topicals, a little bit higher. And I just quoted the high dose group here. And if you look over to the VIGA, again, all statistically significant compared to placebo. So that's a win. That's a win for patients. It's a win for the company. That's a win for us that we have another potential alternative. And then I think the added value is going to be a wait and see, right? Because the added value is going to be, we take these responders and we re-randomize them to whatever their Q8 or Q12, whatever Amgen decides what that's going to be, and see what that looks like. And that'll be the unique factor.
Yeah. But as Eric pointed out, we get limited data in presentations, we get limited data in posters, but the least or the most limited data is when you get a press release, because it's just listing the data that's there, and you can't really look at the details. You're not looking at the baseline characteristics of the population, and safety. Often you just don't get much. I mean, they actually made a comment in the press release about some GI ulceration events, but at a rate less than 1%. And that's a questionable with apathy, whether there's something, but not enough that it made it to the press release. And then, there's very positive data. And I do think that there's a sensibility with both drugs from the earlier studies that if you're a responder, you may continue to respond for a long period of time. I agree. We're not going to get that out of the 24-week results endpoints. And I think there are lots of questions about that overall, and that, is the mechanism of action of these with their differences still incredibly promising, and that it can bring longer term, disease control without a trade-off of infections. We don't really see a lot of infections in either of the development programs that so far, and we didn't know if we were going to see them or not. So it's really sort of quite intriguing, I think, to see where they sit in our therapies.
And like as you mentioned in your slide, they're looking at this pathway to enhance vaccinations, and so blocking that pathway for your pediatric derm audience, how is that? What is that going to mean with this more global suppression? And they probably don't want me to use the word suppression, but modulation. Will that modulation be suppression for vaccine responses, for example? And so, they'll have to do vaccine. They are doing vaccine responses in adults, but I think
I guess we can talk really a very long time period, but we won't, about the question of time course of intervention, right? These studies are all being done in adults now. They're going down to teens in their other studies, and then they'll work their way down. But in our world of peds derm, the question of how's early intervention modulate disease or potentially modulate disease with any of our drugs, and it could be that the different MOAs work totally differently at different ages in terms of its impact on disease over time.
So in summary, OX40 modulation is a new mechanism of action, and it shows that it works. I mean, we don't understand how that's a huge deal. Taking a basic science concept and then showing that it works in humans and human disease, that is extremely rare. We know how we have dozens of mechanisms that do not work, hundreds of millions of dollars. So it's a big deal. Monoclonal antibodies designed, they either block the ligand or the receptor. Impacts multiple T cell subtypes. So that could be good. May enhance T regulatory cells, also may be good. Prolonged clinical results have been observed after drug cessation in the phase 2b studies. Can these prolonged remission times off drug or disease modification be realized? The phase 2b results for Roca, or phase 3, does not appear to be more potent than current therapies, but both drugs may provide very unique long-term benefits. So thank you for the attention.
Great. Thank you, Dr. Eichenfield and Dr. Simpson, for that wonderful overview of the OX40 pathway and all the clinical trial data that's come out from that sense. So we do have a few questions coming in from the live audience. So I'm going to start us off with those. First question is, any labs that you anticipate we may be needing to check before, during treatment with these types of agents?
I already pointed out that we didn't have much of the database. And with the phase 3s, that's what's really going to determine. Phase 3 studies determine if there's enough laboratory abnormalities that it makes sense to test them. And we haven't really seen a drill down in either of the phase 3 studies of laboratory abnormalities.
Yeah, I'll go on a limb and I'll say, I bet you there's going to be no monitoring labs. Just like looking at the phase 2 data, there's no CBC changes, there's no chemistry changes. I think if there's any type of signal of a infection, then baseline immunosuppression lab, make a Hep B, Hep C, HIV, might be warranted at the beginning, like we do for JAK inhibitor potentially. But I bet you there's not going to be. That's going to be my prediction, Larry. But
okay, yeah, don't know.
Well, we'll take bets on it. Okay, so next question. What is the anticipated timeline for pediatric aged clinical trials for some of these agents? Since we are starting to see some of the certainly phase 3 is active, if not starting to lead to some early publications. So any sense or insight into when we might see pediatric data?
I'll start with that one. So I have to say the FDA has been pretty consistent since the time period when we had an FDA hearing to decide how should kids be handled in the atopic dermatitis program. And there was some great work done by that FDA committee and politically for us to lobby for kids being included. And they sort of taken the tack that drug by drug, they'll look at efficacy, but especially safety, make considerations if they're more concerned about safety in kids, and then decide at what point they'll allow kids to be studied. And the more novel the drug is without having its use in other disease states, the more they're going to do it, sort of gated, where they do adults first, or if they don't feel there's a lot of difference between adults and teens, they'll then say you can do the teens second or do them at the same time. And then how they go younger is really going to be a determination. Sometimes they make them go in, gates of basically then 6 to 11, and then down from there. And companies have the decision to make really after their phase 2s. They have to come up with their PEDS plan, both in Japan, Europe, and the U.S., of how they're going to handle that and file it and then go forward. So both of the drugs we discussed have done or in the process of doing their teen studies. And so they've in process, I think one's fully enrolled, one's in process of enrollment. And I believe that they're both gated to not go younger than teen until they get those results. But Eric, you agree? Is that your
That sounds right. But I know both of them have adolescents in the program right now.
Great, thank you. So in the webinar, you guys presented some of the data for Rocatinlimab and Amlitelimab, but we also have a third OX40 inhibitor, Telazorlimab. Is there any information that you can tell us about that particular medication? Is it similar or different from Roca, which is, they're both inhibitors of the receptor, but, is there anything to distinguish, I guess, Telazorlimab from Rocatinlimab? Any data that you guys have on that?
I remember, I thought it was IV, but no, I think it's sub-Q. I think it's the receptor. Yeah. So that I bet you the difference is that it is fucosylated. And so it's probably, which is good because we don't know which approach to take. So it's probably like Roca, but doesn't remove pathogenic T cells. If I just had a guess, someone would have to double check me on this. But usually when it's non-fucosylated, that's kind of like a special, they call that out. And I've never seen that called out on Tela. But I also don't know, I'm not aware of it going into phase 3.
Yeah. And I don't know enough yet to make comments in terms of differential binding characteristics and pipeline. So that was enough data to judge.
Yeah. Okay. So it seems like more to come on that for all of us here. So great. For the sake of time, I'm going to, maybe just ask you guys just to very briefly summarize what you think the specific advantages are of these OX40 receptor or ligand inhibitors that we've discussed, and maybe what are the specific limitations for us to keep in mind. And then we can later on transition to our podcast discussion to delve into some additional topics.
Sure. Yeah. I'd say the advantage is Q4 dosing right off the bat. So Q4 week dosing. So fewer injections. The possibility of impacting more T cell subsets, which usually you would think translates to higher efficacy. But it hasn't been realized yet. And then of course the potential for prolonged responses, either off drug or longer intervals of injections in responders. Those are the main ones that I can come up with without conjunctivitis.
I'll agree with all those, but I do wonder in reading the data, it's just my reading, my interpretation, that there are going to be subsets of individuals who are really high level responders and persistent responders, and it just makes sense that can happen. But if you're blocking proliferation of a subset of cells by either blocking their proliferation or by depleting them, that may impact people differently. There are lots of different, characteristics of our atopic dermatitis patients. Even those with persistent disease have different things that flare them. So I do think that this is a fascinating foray into what can be differing biology of individuals. And, Eric had the key takeaways, but I do wonder that if we can figure out which patients can be those longer high level responders, it would be tremendously great for them. And then of course it'll have all these questions about if it's effective at decreasing a long-term set of cells over time, how that might impact on the course of disease, especially in younger individuals whose immune response is so plastic at the time at which atopic dermatitis is being developed.
Great. Wonderful. Well, thank you, Dr. Eichenfield, Dr. Simpson, for a really fantastic educational webinar on this pathway. And thank you, everyone in the audience, for joining us for this webinar today.
Thank you again to our expert presenters, Dr. Lawrence Eichenfield, Dr. Eric Simpson, and our fantastic moderator, Dr. Joy Wan. Special thanks to Amgen, Sanofi, and Astria Therapeutics for supporting this independent medical education program. Pedra is solely responsible for all program content and the selection of presenters, authors, moderators, and faculty. If you have questions or comments, please email us at info@pedraresearch.org. Please make sure you're following us on social media at Pedra Research. And lastly, make sure that you have liked and subscribed to the Pedra Pearls podcast channel, as we will be following this webinar with a podcast-only discussion between our esteemed guests, Dr. Eric Simpson and Dr. Lauren Seichenfeld, led by Dr. Joy Wan. That will be released on July 7th, so keep an eye on the Pedra Pearls feed. Thanks so much for watching.